What's up, guys? Welcome to the PT Good Podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And I'm Mark.
All right, Mark. So what is on the agenda for today?
Kane. All right. What we want to talk about today is what rehab looks like after a total hip or total knee replacement. We're going to look at, what we're looking at pre-op, if they have a pre-op evaluation, what we're looking at post-op, things we focus on from a rehab standpoint, and just general expectations, time frames, what people can expect after either of these kind of surgeries. It's okay. Let's start before the surgery. Are you typically seeing either of these kind of patients, knee or hip, before surgery? Are you doing a prehab? Like, do they come for an evaluation before, just to get things checked out before the surgery? What's that look like?
So all of our approved post or total knee patients come in for a pre-op eval, every single time for the most part, unless something happened, unless there was a traumatic event or anything like that. If it's a planned total joint, they are almost always getting a pre-op eval. Pre-op eval for us is pretty much running through a total joint packet, and then just educating the patient in regards to what their expectations should be, how to do things safely, what they may feel coming out, and just making sure that you've told them and prepped them for what it's going to be like coming out of surgery.
Mm-hmm.
The other things that we do is just getting your baselines, making sure that you are getting their strength levels, their level of function before the surgery, and see where they're at. The other thing is making sure that they know what exercises that they can start on, nice and easy, table stuff or range of motion stuff that is very easy to kind of navigate through. That way they can kind of get started on that while they're recovering for the first few days. Usually we'll see people post-op within 3 days. But if they're an out-of-network doc, we do not typically see them preoperatively. Mm-hmm. And then I think you mentioned prehab. That does not happen very often unless I'm seeing them already and treating their knee or their hip, and I'm like, hey, I think it's time for you to talk to your surgeon again, or to reconsider whether or not you want to have a surgery, just based off of how they're presenting and stuff. So prehab doesn't usually happen very often, at least not directly. It's more or less just a byproduct of me trying to address their symptoms and whether or not we can get a change. What about you? What are you seeing for these?
Yeah, I mean, we do the we do the pre-op appointment. I don't know how much. I think the most value that comes from the pre-op appointment is the educational component. I don't really. I mean, I get that, you can do objective tests, you can do have them walk, see what their ambulatory tolerance is, stuff like that. I'm not too concerned about that kind of stuff, because I feel like the patient's subjective report, or just how they feel they're doing after the surgery, is going to be the biggest indicator of progress, right? So if I do these kind of objective things, range of motion, strength's fine, but having them walk and do different things, it's I feel like they're going to figure that out on their own if they feel like the surgery has brought them past their prior level, right? So what I focus most on the pre-op eval is, it's surprising to me how many people I'm like, hey, so did they tell you about what happens after the surgery? And they're like, oh, they just said, I don't know. They said, I go to the doctor 2 weeks after. It's yeah, but you're going to be here 3 days after, right? So, I mean, there's something missing in that regard. So I tend to focus on that at the pre-op eval, right? So you get the surgery, you'll wake up in the hospital, they'll have you walk, they'll have you do the stairs. Once you can do that, you can leave. Maybe it's the same day, maybe it's the following day, right? So then they start to think, oh yeah, what? Actually, now I think about, when I go home, I have this many stairs, and I got to go up to my bedroom, and the only thing I can sit on is a couch, right? So then we start talking about these things. What's your home look like? Where are you going to be sitting? What legs is your position going to be in? What kind of support, if any, do you have at home? Someone going to be able to help you get around? When are you going to go back to work? All these kind of things that, maybe they're not commonly glossed over, but at least I don't find that people think about it in this much detail. So we have that kind of stuff to talk about, stuff to bring up. And then yeah, we're talking about, hey, this is going to take maybe 2, 3 months, maybe more, and people don't get that. I don't get, not that people don't get it, but some people are like, they think you get the surgery and that's it. I don't really know why I got to come here. I do. Here, let me tell you. Right? It's like, it's it can be comical at some point. So yeah, the education components, like for me, the primary thing I go over at the pre-op eval. Let's talk about, you want to add anything to pre-op eval? If not, I want to prehab. I think is an interesting subject.
Sure. I think the biggest thing, and I would definitely agree with Mark on the patient education. There are so many times that I've seen the patient and they're like, okay, so did the doctor tell you anything about what to expect following your surgery? Like what your outcome should be, maybe what you should feel after the surgery. And they will often respond with no. And sometimes I've even seen where the patient will say, I was told I wouldn't have any pain after the surgery. And I'm like,
it's gonna be fixed. It's done. The arthritis is out. It's gone.
Yeah. Like, brother, like it's still a major surgery that you had. You're going to have to recover from it. And depending on how you do, and I do think that the quality of the surgeon makes a difference. But even then, the quality of surgeon, they can't guarantee that it's going to be the same outcome every single time, So it's just like, I say, imagine the best possible outcome where you come out and you're walking, you have no issues whatsoever, and you don't even need me. And then the other end where you can't walk, you're in a whole lot of pain. Your function is limited for a very long period of time. You have like persistent issues that aren't improving. And I think that the way that I usually explain to patients is I lay that out to them like, okay, and now find the middle ground. Right. That is most likely where you will be. And that is to say that like, not everyone is going to present the same way after surgery, but you can definitely expect to have some deficits coming out of it that you need to work on. I think that is like really, really important to preface and get our patients on board with, because then they're like, oh, okay, this is going to take time. I'm going to need to work on this. And then also, I can't really compare my surgery to someone else's.
Yeah. And do you give like regarding expectations? Like if someone is, this is a chronic issue, 15, 20 years, they have significant moderate to significant movement loss. They're not in great shape. They're overweight. Their strength's not great. Like, do you adjust our expectations in that regard? Or do you at least, do you start to change your expectations, or do you just kind of leave it open?
No, so I'm pretty quick to address their expectations. Like I'll usually, like I said, I'll ask them like, what has the doctor told you? What do you know? Like what are your kind of expectations coming out of surgery, and where do you want to be, and how, like, I'll usually ask them just to see like where their head's at in regards to this. And then that's where we have that conversation. And I try to clarify it up as best as I can. Like, hey, so if this is where you think that you should be, this is what I'm seeing. And I'm like, this is your first time going through this for the most part. You don't have any prior experience. You don't know what it's going to be like and what to expect or anything like that. But I've seen a whole bunch of them, and it becomes like, okay, like I said, you average it out. Not everyone is going to do amazing. Not everyone's going to do terribly. Usually they're going to be somewhere in between in regards to that. So you just kind of prep them for that. So that way, if they do well, awesome. You over-delivered and they're like, oh, that was nothing to worry about at all. Cool. But if they have issues, then you're like, okay, like we talked about this. This is something that can happen following, and it's something that we're going to need to work through to be able to get you back to where you want to be. Yeah. So I think addressing those expectations early on and just like reinforcing it is really, really important, because I usually tell patients too, like, hey, at the end, when I discharge you, you may not be back to 100%. That is like very realistic. If I can get you back to like functioning and like I expect you to continue making progress, or we've plateaued and I think that will take time, that's okay. You're going to need that time. It's not like it just gets better all of a sudden. Like, I don't know about you, but I usually say like it takes about a year for the joint to fully like settle in and for you to think of it as yours. That's typically what our surgeon has stated as well too, where it's like it really does need time to like for your brain to make that connection, for you to get used to stuff and for you to chip away at some of your deficits. Like, it doesn't just come back all of a sudden. It's like it's a completely new joint.
Yeah, it helps when like you said, the surgeons, if the surgeon's time frames has a similar time frame, or at least they're relaying a similar message to the patient. Like, I have patients come in like, oh, the doctor told me it's going to take like 6 months to a year. Perfect, right? Yeah, agree, right? That's probably how long it's going to take before you start to surpass whatever your prior level was. Yeah. How about like prehab? I don't know. I think it has a place, but like, is there anything? Like, if someone comes in for prehab for me, depending on the time frame, like sometimes the doctor, prehab 1 to 2 visits before PT. I usually don't even see them. I'll see them for one, pre-op eval, right? What am I going to do with the second visit? I don't do it. But if they're like, hey, you should go for 4 to 6 weeks before, especially if it's someone, and this is when I find it has the most benefit, someone who's like just generally deconditioned, which their body's going to take, like, the surgery's going to have a big toll on their body. And especially if they have like quad strength or knee extension range of motion loss, like I'll focus on that stuff for them, right? I find that if we can like start to get that stuff back, just general full body conditioning, just some exercise, and then when it comes to the knee itself, quad strength, knee extension range, I mean, pre-op I think has its place if you have somebody with those deficits. Yeah, I mean, especially if it's someone's on board, like, hey, we're gonna push on your knee, you're gonna try and get it straighter. It's probably gonna hurt. You're gonna get the surgery anyway. You can start to push through it a little bit. Like, that's where I find prehab has its place. If I have someone coming in minimal deficits, they're generally active, healthy, they're just gonna get they're just gonna have a surgery. I don't find they really need to come to for like prehab type stuff. Maybe a couple sessions if they really want to learn about like what it's going to look like afterwards, or exercise to do after. But I find I can usually get most of that, if not all that information, done in a single session. But yeah, are there any like certain presentations, certain deficits, impairments that you see in this population where you feel like a rehab sessions, whether whatever amount of time, do you feel like it's appropriate in any regard?
Based on what you just said, I feel like prehab for 1 to 2 visits is going to do nothing. That's not enough time to actually address the deficits.
You get referrals like that where it's like prehab 2 to 3 visits, and it's like,
no, I actually do not get any in regards to that. I think that it's like, I think that time frame is way too short. But for a patient to come in and to work on their strength and whatnot, sure, you can improve on their conditioning, and at least they're familiar with the process of what they need to do, right? I think that is like the biggest value, but I really don't think you're going to make a huge amount of change. And the other thing is, if you restore their range of motion, is that going to carry over for following their surgery? Like, the only thing that I could honestly think that prehab, and I don't even like the term prehab for, at least for this case, because to me, if I think prehab, I'm just prepping you for your surgery. We're just working on your strength and mobility and stuff like that. I haven't actually, like, to me, it doesn't require as much troubleshooting. But imagine that you actually identified impairments, worked on them, and they got better. And they didn't end up needing a knee or a new knee or something like that. I think that would be cool, but I just don't see that usually being the case unless they were poorly identified as a candidate. and that has happened previously.
Yeah, yeah.
And I don't know if it's the best thing, but I've had it where I'll do repeated knee extension on a patient and all their pain is gone. And they're just like, do I still need surgery? And I was like, that is something you may want to chat with your surgeon about.
Yeah.
And that to me, I think is like, it's an interesting line to teeter, because it's like, A, I just stopped you from making money. B, I just prevented the patient from needing a major surgery and incurring that loss of time, resources, etc. And because the thing is, you don't know what the result's going to be like following a surgery, and a lot of people report, man, I wish I didn't get a total joint surgery after, when they're just like, maybe I didn't need it. And they kind of got pushed into it, or maybe the imaging tells you otherwise. And it's like, hey, you're really having major changes here. You're like, you're bone on bone. Like, this is like the worst knee or hip I've ever seen, and you really need it. And some patients are like, oh my god, I guess I do need it. But lo and behold, you address some of those deficits and it's gone. And given this hasn't happened very often,
Yeah.
but it has happened enough where I'm like, even the surgeon that I work with, who's good, I'm like, dang, so this is like a really tough line for me to tread on, where it's like, do I just tell you, hey, you probably don't need the surgery, and ruin that relationship? Or like, well, I wonder what the surgeon even thinks. Maybe he's like, oh, that was cool, you fixed that. Or maybe he's like, dang, I wish that you didn't fix it, because I would have made more money.
Yeah, I find
know?
most of the time they end up excuse me, getting the surgery anyway. Surgeon's just like, well, the arthritis is still there. You're gonna need it eventually. It's kind of like, all right, whatever.
That's fair. That's fair. And I think the other thing is the time frame that happens. Most of the times the pre-op happens within just a few days.
Yeah, a week to a few days, yeah.
Yeah, from the surgery. So I'm not gonna tell you, hey, cancel.
Yeah,
But if it's, I've had it where some patients come in for a pre-op and it is a few weeks in advance. And that is usually like, if I am able to make changes there, then I'm like, hey, you haven't had pain, you haven't had any of your symptoms. Go talk to your surgeon. See if he thinks that's still appropriate. See if you still think it's appropriate.
Yeah.
And kind of go from there. Like, I would feel bad, but at the same time, total joints are so interesting, because it's like, when do you push for a patient to get the surgery versus withholding them from it? Because you don't want to do it too late where their functions deteriorated, affects their quality of life. And it's like, oh, you waited too long to get the surgery. Now your joint isn't going to come, like, you're not going to have the same function, right? Or if you get it too soon and you're like, my function was still good, but now it just doesn't feel like how it used to. I thought I was going to do better. So it's a very interesting line to kind of teeter on these recommendations, because like you'd want the surgery to go smoothly and successfully, but you can't guarantee that, And I think that's really tough for us to make that recommendation, aside from obviously the easy cases where you're like, oh wow, you've made no progress, you need a new hip.
Yeah, it's funny you say hip. I was just gonna say I'm much more likely to, if I do recommend a joint replacement surgery for a lower extremity, much more likely to recommend hip versus knee. I mean, at least what we see from an outcomes perspective, I find if people get like a hip replacement, especially an anterior, like they just end up, they're fine. Like 4 to 6 weeks, so like, oh yeah, I'm good. Especially if they have their flexion range is like really limited, internal rotation, like weight bearing pain, like they just it all adds up, and they go in and get an anterior done, and they usually come out pretty good. But it is a like I said, it's kind of like, where's the line where you make that recommendation? I typically, I how should I put it? If especially if they're coming for PT for their near hip, and we've gone 6, 8, 10 weeks, whatever it is, and like, yeah, it makes some progress, but it still hurts, it's still functionally limited. I leave their discussion up to whoever their surgeon is, have them discuss it, and then kind of go.
Yeah, I would definitely agree with that. Like
Yeah.
it just it's definitely tough because like we just view things from such a different perspective,
Yeah.
you know? It's like, well, one of them is a lot more like imaging based, right?
Yeah.
That's what they usually use to determine their criteria for surgery. And also, this is their solution, right? This is what they do.
Mhm.
This is what they're good at. So that is how they help their patients. Surgeons are going to do surgery. Versus us, we view it from like a symptom management or presentation standpoint. And if we're able to make changes in those symptoms, then I think that is like, that's just the biggest difference is like, that's how we help patients. So, one of them, increases how much money a physician makes. The other one definitely does not.
Yeah, the dynamics
you know?
interesting. Yeah.
So I think that is very interesting to see and to kind of like navigate through that because you want to make sure that you're informing your patients of like the right stuff and to give them the available information for them to make the best decision for themselves. And that's usually how I kind of approach it is like, I want to leave the decision up to the patient. I give you all the information. I'm not telling you what or what not to do unless it's something that's like egregious where I'm like, wow, you're totally fine. You do not need this. But it doesn't, that is like a very, very rare case. I almost never see anything like that.
What are you doing? Like, do you see any, like when we're just comparing knees and hips, like do you find one typically does better? Do you find, maybe we can go to hip too. Do you find like a certain approach works better?
Oh, dude. Total hips do infinitely better.
Yeah, I saw a
than
post and it
total
was
knees.
like total hip replacements are the like most successful orthopedic surgery in like the last like 50 years or something like that. And they just end up they just do fine. You know what I mean? They come in, they're like, yeah, I don't have that groin pain anymore. You know, their hip moves. It's just like they just end up doing well. Yeah.
Yeah, like there are more I guess you could call them anomalies, but it's like more commonplace to see people who don't need rehab at all.
Yeah.
Following a total hip or they're in for like 2-3 visits tops and you just ship them, you know, but I've definitely seen more stubborn joints when it comes to knees. I think from what I've seen, the approach for hip doesn't matter in the long term quite as much, but it definitely matters for the short term. Like it washes out after a certain point. But dude, I feel like to me, if you are able to get that short term success, that just makes things so much better for your patients.
Everything else
they don't
follow.
have to suffer. Yeah,
Yeah.
like they just improve a lot faster. There's no precautions, no other risks for that. For like complications there, I think it just makes it so much easier for patients to get through. They don't have to worry about any of the other stuff.
Yeah. The only thing I see with like anterior approaches for hips sometimes is that their hip flexion and knee extension strength sometimes lags behind compared to the posterior approach, but their range and function is a lot better early on, right? So, you know, yeah, as long as you can just kind of build that strength back, which comes along, and like you said, like long term, you know, maybe there's no difference. But if why wouldn't you pick the option that has a better short term outcome, or you don't have as much pain early on, or you're able to move better earlier?
For sure. And like I said, it gets rid of those like the precautions. So it just makes your outcomes that much better, you know. But the thing that I'm seeing for anterior approaches for the more difficult cases with them are that they will usually have deficits in their hip flexion, like range of motion. And then the second thing is trouble with their scar. Like I've seen a handful, especially lately, where their scar is really, really fibrotic. And that is what impedes on their range of motion and function. Like this one lady that I was treating for a total hip, she's like strong. She has no issues or anything, but she has like I don't even know what you'd call it. It is a hard mass underneath her incision. And I even had a couple of colleagues come over and take a look because I was like, dude, am I feeling the implant, like the joint? Like this doesn't feel normal. It felt like a baseball underneath. And they're like, that's a scar tissue. That is literally just the incision becoming fibrotic. And I'm like, oh my God, like I cannot move that thing. It is not changing. Like I didn't know at that point, and I was like, huh, yo, so keep working on it. I don't know how much we're going to change this based off that. I can't just like break up that tissue. It's there. I don't think that it changes much, to be honest with you, either. So that's where I'm like, maybe that's something you have to talk to your surgeon about. It was one of the first times I'd ever seen something like that where I was like, wow, that is not moving. I've had other people that have issues with it, but it was not nearly that bad. It's just like, yeah, it's hard, but
yeah.
it's nothing crazy that really stuck out to me.
You have people do oh yeah, go ahead. Yeah.
Oh, I was going to ask you what have you typically seen? Because you'll actually see more posterior or lateral approaches. I only see anterior approaches.
Yeah. I mean, the posteriors, they're just like, excuse me, they come in stiff. Pain's usually not too much of an issue. Yeah, they can move, but they don't really. Said you got those restrictions you got to follow. So just because of that and because of the approach, you're just gonna inherently have some more limitation in range of motion. Strength, like I said, compared to anterior, seems to come along better, but it's not like the anteriors are like lagging too far behind. But like overall, the anteriors just seem to do better quicker. That's what it comes down to. They have less pain. They're able to move more once the strength evens out over a couple weeks. Like they just do better.
For sure. All right. So we talked about pre-op and prehab. Yeah. What do you usually capture when it comes to post-op? What are you looking for?
So the first couple weeks, it varies slightly differently for, well, I'll speak about it generally and then maybe we'll go into like what it looks like comparing hip and knee. But the first couple weeks, just get some joint movement, some muscle activation, and the biggest thing for me is managing the acute inflammatory response, which is the main thing we're looking at. The patient's going to measure is the swelling, the irritability, right? You're going to have some of that stuff in the beginning just because of the nature of the surgery. It was an acute trauma to that tissue. So we don't want to do so much early on that we make that angry and it sticks around for longer, and then it limits range of motion. It's more painful. We can't do as much, right? So that's a huge thing, especially after. I'm like, listen, I want you to do a little bit of this, prop your leg up, move your knee back and forth a couple times, lift, do this, blah, 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 all that kind of stuff. But, we're going to play around with the frequency. We're going to play around with the dosage. If you feel like, you get some more swelling, it doesn't come down, you have increased pain that sticks around and you don't feel you can do as much the next time you do these exercises, yeah, we might have to back off a little bit, right? But otherwise, you can poke into the pain a little bit. If it ggets a little bit worse, it's okay. It shouldn't stay worse. You probably should have some kind of symptomatic response as you're doing these, right? Like some people are like, oh yeah, I did the thing where I propped my leg up and it felt fine. And then you're like, I did it in the recliner or whatever. And then they show me and they're not even at, 10 degrees of knee extension, right? Or they're in 10 degrees of flexion. So it's just like, yeah, like I try and explain to people, you should, you'll feel a little bit, right? Work into it a little bit. Shouldn't be worse afterwards. Monitor your swelling. But yeah, first couple weeks, we're just movement and then just letting the swelling come down. Then after that, then we can start to try to load it a little bit more, right? Weeks, maybe let's say 3 to 6, a little bit of resistance, maybe some more like focus on weight bearing, standing interventions, normalizing gait, stuff like that. And then after 6 weeks, looking ideally maybe 6 to 8 weeks plus anytime after that, looking to get rid of the assisted device if they're able to. Everything should be like, a little bit more pushing the resistance stuff, functional type activities, weight bearing type exercise, whatever the person needs to get back to. But yeah, the one thing I've really that has like I feel like has evolved even like before I started practicing was the tendency to just like crank on a hip, or not maybe not a hip, but like just crank on a knee, get that extension, get that flexion back. It seems to be now that the less and less people do that, including myself, and it's more so, especially in the early stages, like, yeah, just get some movement. We don't want to, we don't want to make the joint angry. We don't want to make it more irritated. I think the person's just going to guard. The swelling's going to set us back in that kind of short to medium term, and it doesn't seem like it aids the long-term progress.
Yeah, I would definitely agree with that. I tell my patients straight up right away, like, I'm not someone who cranks on a joint. Yeah. I just range you. I get you to move. I check out your end ranges, your end feels, and if it continues to loosen up, awesome. If it, as soon as it plateaus, we're moving on. I let that joint do whatever it needs to do. The other thing is I start to actually load them to get more range. So like for leg press, for example, I know a lot of people love the leg press. I usually hate the leg press, to be honest with you, but I will use the leg press early on because it teaches you how to load and go into extension, or to load and go into deeper knee flexion. I'm using that to my advantage. I'm not using it for strength because, let's be real, the reason why I hate the leg press is because most of the times people set it for like 80, 90, 100, 120 pounds, somewhere around that range. And the average person weighs way more than that. They're already squatting. Like, what is the leg press going to do for you in that sense? So that's my soapbox on the leg press. But I will definitely use the leg press to improve on their functional like range of motion, and to just see if we can push it a little bit further, if it can handle that little bit of an oomph. But I do want to share a couple of things. I think that what you said I thought was really interesting, because it seems like I tend to load people a lot faster, based off of like the time frame that you kind of gave. How quickly do you introduce, or when do you introduce like more functional stuff? When do you have them like start squatting or doing any type of pattern like that?
I mean, they could be doing like an elevated sit to stand at like second, or third week, or even, whenever. I mean, maybe even earlier, right? It depends on the person. Hips probably go quicker, right?
Yeah.
But really, the joint irritability, especially early on the pain, the symptomatic response dictates a lot of what I do.
Sure.
I mean, I get the standing stuff pretty quick. I don't really do, besides, your basic stuff, like I try and get them up as quick as possible. Though they can do their heel slides, straight leg raise, whatever else they want to do at home to stretch. Like when they're in the clinic, I feel like, all right, let's work on your function. Let's have you walk. Let's have you step over things. Let's have you stand up and down, right? So I get to that. I guess maybe the way I phrased it earlier made it seem like I go, it's not like I go extremely slow when it comes to function, but I feel like getting the range of motion, mobility, and just getting things to calm down early on is like a big thing that I try and educate the patient on, right? When they come in, stand in, walk in, that step in, balance, stuff like that. We're starting to progress in that regard. But yeah, I mean, I get to it. I just don't. I'm of the opinion that especially the first like month or so, first couple weeks, like just letting things settle down, letting the body kind of do its own healing process, and then just aiding it, and then having the patient do functional things not at their own tolerance, but I guess at their own tolerance with our guidance is kind of what I focus on. I don't push it to the point where it's like, like week 3 or 4, I'm not, unless they can just do it easily. I don't, if they want to do a sit to stand, they want to use their hands, it's fine. Like I'm not pushing the functional stuff like past a certain like threshold of pain or that symptomatic response early on. I don't find a ton of benefit from it. I mean, like I said, it's all dependent on the patient, right? If they can handle it, they don't have that joint irritability, they're moving fine, swelling settling down, yeah, we can work into it. But I guess I might wait a little. It's tough. Can't give you an exact time frame, right? But maybe after a month, I guess on average, I will start to introduce like some of the more demanding functional things.
Interesting. Yeah. So like,
I'm big. Dude, I'm just like in the beginning. I mean, I don't know. I'm just like, I guess I keep it a little simple, like range of motion, some isolated muscle strength, and then just letting things, ambulation, and just let things settle down. Yeah.
Yeah, that is like a very different approach, and I've
Mhm.
seen it among the different clinicians at my clinic, where a lot of them will start off with like your usual, heel slides, straight leg raise, quad sets, hamstring glute sets, long arc quads, short arc quads, stuff like that. I am much faster to move on from that. I usually don't do like long arc quads or short arc quads very much
Okay.
unless it's
Yeah.
like they're really symptomatic, or they just can't do a lot of stuff. I prioritize for the most part like your heel slides, your single leg raise, or sorry, straight leg raise, and then after that I pretty much get you doing like a squat pattern in some way, shape, or form. Usually
Yeah.
it's I found that sit to stands are actually a lot harder for patients for the most part. I'll usually have them do like a TRX squat or a squat at the counter. And I'm just like, just go to whatever you think you can do.
Yeah.
Just let your knee move. And I tell them, like, if it's painful, if it's like really painful and stays painful, we'll back off. That's okay. But your knee is meant to move. Like this is fine as long as it's not continuing to further irritate it. They usually tolerate that a little bit better than say like ranging them. Most people don't like that because it's tight,
Yeah.
it's just uncomfortable. But when they squat, we're working on two things. You're working on that range, and you're working on getting some of your strength back and developing that pattern again, and just improving on your motor control, because you're going to have those like compensations coming after a surgery like this. But yeah, that's like my big thing is I usually start to load people a whole lot faster than what I've seen some of my colleagues typically do. And like I've usually seen improved results from that. But I agree with what you said, because like you want to make sure that the joint is happy and not like you're not further provoking it. So you're still going based off of symptom response.
Yeah. I mean, I guess I should say too, like, it seems like the amount of swelling they come in with, or like how that swelling changes over the first week or two, has a lot of value, or
Oh
it gives me a lot
yeah.
of information regarding like how I think things are going to go, just outcome wise too. You know what I mean? Some people come in and their knee is just like blown up, right? The outside of their hips just like a ball, and just like, what is going on here, right? And then some
Yeah.
some patients come in and they're just like, their joint's not even red. They're just like, yeah, yeah, it hurts a little bit, just like, okay, you're going to do great, right? So that plays a big role. Well,
I couldn't agree more. I think that is very telling. Like the key things that I'm usually looking for is like a quick change in their swelling, or quick changes or reduction in their pain, or if their pain is even an issue in the
yeah,
beginning. If it's not, that's huge.
right, yeah,
Like their strength, I think that's super important. But like quick changes in swelling, pain slash symptoms, or your motion, I think that is all very telling of like how they're going to
yeah.
progress and what their outcomes are going to be like.
How do you like after the surgery, like talking about movement, like how do you progress range of motion? Like, are you looking for it to improve pretty steadily? Do you get to a certain point, whether it's like a certain plane of movement? It's like, okay, you have um 110 degrees of knee flexion, like that's good enough. We're going to focus on other things. Like, how do do you draw a line? Do you have them continue working on it? Do you continually reassess it? What's that look like?
Sure. I work on extension like pretty heavily early on, because like you need terminal knee extension. You need as much of that as you're going to get
Yeah.
back. Like I try to get patients at least to zero if
Mhm.
I can. And it's just like hang out there, keep your leg propped up. Even if you're like sleeping, keep it elevated, keep it propped
Uh-huh.
up still and straight.
It,
Sometimes I'll give them
yeah.
the backpack trick, where you have your
Oh
legs
yeah, yeah,
straight
yeah.
you slide the backpack over your knee with a weight or something and just hang out there. I've had to do that for a couple of people, especially if they come in walking with a flexed knee for a prolonged period of time. That is such a problem. You want to nip that early on as best as you can. For flexion, on the other hand, I will be my criteria to kind of look for whether or not I should continue pursuing this is A, are they functional? B, what does it look like compared to their other side? C, how does their end feel? And what's their symptom response at their end range? So if they have very consistent pain that doesn't really change and it gets flared up at that end range, I'm probably not going to force it. But if their end feels good, then I might be able to get a little bit more. But if it's hard, then I'm like, I don't know if we're going to keep going with this. Usually if it's hard, that's when it's painful. But if it's empty, that's when I'm like, we still have room to go. We just need your symptoms to calm down more, and we'll be able to continue going. So that is usually what I'll look for, is like, it doesn't need to be perfect, and they definitely understand this for the most part, but you definitely want to get as much as you can and make sure that you're not giving up on that like super fast, because once a certain amount of time passes, it becomes really hard to continue to get that back. So make the most amount of change early on as you can. And once you've covered like 95% of that, that's when you can expect the patient to continue to improve with more time and more reps beyond your care. So that's typically what I'll look at. What about for you? Do you focus a lot on their range of motion, or once you get to functional, you're good?
Yeah, I mean, honestly, like some of the especially the first like week or two, like, I mean, we're like essentially only doing range of motion. I mean, there's other things, right? But like the big focus for me, I mean, if I can get the range back, it makes other things easier. We talk about walking, right? If they can start to, fully straighten their knee, then they're getting, they're working their quad to end range anytime they get up, right? Same thing when we're talking about quad. Like, I mean, if they're lacking 10 degrees of extension, like I don't know, how much they're going to get out of their strengthening interventions, or at least they're not going to be as effective as if they were to have that extra 10 degrees, they were able to get to neutral, right? So I'm typically like, I'm at least assessing range of motion until I get to the point where they are full, unrestricted, end feels good, right? But yeah, I'm usually working on it in some capacity, like every session, some kind of end range strengthening, or whether it's like passive range of motion, active assisted, whatever it is, right? We're working to it. So I don't really have like a number to get to. I usually just compare to the other side. Some people are pretty insistent on that, that it's got to be the same as this side. All right, we can get there, right? Sometimes that side's restricted, so we get there and it's easy. I'm like, cool, done. But yeah, I mean, I think range is important. We talked about this in previous episodes too. I think like just mobility, range of motion is just like seems to clear a lot of things up. So even like when we look at post-op, like just kind of making sure we get as much as we can out of it. And like you said, like we don't want to give up on it too early. Once those tissue changes set in, it's just so much harder to get out of it. So at least the first 6 weeks, it's a huge focus, along with, some of our other things. But yeah, I don't have a hard cut for when I stop it. But, if I'm ranging someone and like, 2 weeks in a row, they have full knee extension, it's unrestricted, they can get there on their own, they lie on the table and it's there. I might not do it anymore after that. But
yeah,
it's I think, I mean, it's obviously important, right?
For sure. So like, I feel like mobility is a really important thing that we address, but it's kind of early on, and I think like that's usually why I value and why I put in functional loading so much faster than a lot of my other like colleagues, is because when you load someone, you're like I said, you're killing two birds with one stone. You're working on their range. You're teaching them like, hey, this is what it should look like. Go at your own pace. Do what you can. Go as far as you can tolerate. And that's gonna kind of help your body realize, oh, we're safe to move here. We can gradually improve and do more and more. And I think that loading is what helps me be able to get their range back a lot faster, because it's just incorporated into all their exercises at that point. It's like both for squatting, when they're going up steps, especially when they're going down steps. I think that is where you get to really focus on both the flexion and the extension components, while still hitting all the checking off some other boxes as well too. And it's just like, to me, a little bit more efficient. And I like it more because the patient's also under control. It's not me just moving their knee or anything like that. And I think patients tend to just be more comfortable when they are able to like figure out like, oh, okay, this is what it feels like when it's not good and it's too much, and this is what it should feel like when it's just like a normal like pain that's just like from it being stiff or anything like that.
Yeah, like I like you said, they're in control of the range of motion. I mean, I know the clinic I work at, we have like it's called a Vigor gym, but it's essentially like a total gym type thing. It lets you change the range of motion, the amount of resistance they have, so you can set it at a low level when they're early on, and you can just have them, work into that hip flexion, work into that knee flexion, with like really minimal resistance. But it puts the person in control of their range, their resistance, and then it lets them build that tolerance. So in a functional way, so then if they're standing up from a chair or sitting down, stuff like that, they're able to use.
Yeah, I think that tool is actually so helpful. Like, I really miss having a Vigor gym, because you don't have to range them anymore.
Yeah.
After that. It literally is functional loading, and that is exactly why I like it so much. And you could probably introduce that so early on, like pretty much almost day one.
Yeah,
day
no,
two.
seriously, for sure. It's like less intense than the bike. Like coming out of it, you don't have to push through that range.
for
Just set the
sure.
resistance down. Yeah, so nice.
God, patients hate the
Yeah.
bike, especially when they haven't made that first revolution yet. There's like, oh my God, I don't want to do this again. Yeah, that I always feel bad about giving to the patient, but I know like I've gotten to the point where I don't usually give them the bike if they haven't made a full revolution. I find that it just tends to be like
same.
very discouraging for them, and painful. So when they have the range for them to be able to get over a revolution, then I'm like, okay, hop on, we'll try it. But the first time when they're like, oh, I made that turn, and they're like, oh my God, that is killing me. And I'm like, maybe.
Do you help people around it?
Wait a little bit.
Do you push through it? I've done it a couple times, but it is like
no,
an extra.
Not typically.
It's an extra stretch. You know what I mean? You got to push it. Yeah.
Oh God, no, I feel too bad. I cannot do that. I usually will keep patients on the new step, and then I'll range them and work on it, see how it continues to move. And when they're finally improving or have improved enough, that's when I have them hop on to at least test it out. All right. So one of the things that we did chat about, I wanted to go back just because I wanted to make sure that we addressed it, is like for your post-op evals, what are the like functional tests that you use to capture for your baselines?
Honestly,
like,
I don't.
Is there anything?
Yeah, dude. I mean, if it's immediately post-op, a couple days after, I just don't do them. I don't know
really?
I mean, I don't know how much value I'm going to get out of asking someone to do a tug and have it take them like 90 seconds, and then a month down the line, oh hey, look, now it took you 25 seconds. Last time it took you 90 seconds. To me, it's like, well, yeah, I just had surgery, right?
Sure.
I mean, from an insurance standpoint, I got enough deficits, right? The person can't walk, they can't move their leg, they have no range of motion, right? What I will do typically is maybe they've been coming for like 4 or 5 weeks. Then if they can actually perform these tests, then maybe I'll look at it, right? Maybe they're doing sit to stands. Like, hey, if you cross your arms, can you do it? Okay, here, do it 5 times, right? And then I time them. Or, where I'm having a walk, they're, using a cane instead of a walker. Hey, just go, I'm gonna put this thing down, stand up, walk around it, come back, right? Then maybe I'll work on it. But like I don't find I get really any value out of doing it right immediately post op. It's almost like I don't know. I mean I think we know. I think the patient knows. Hey, their scores are going to be horrible. They had surgery
Yeah.
2 or 3 days ago. I don't. Do you do those tests? I mean, and if you do you find it gives you any value? To me, it just I don't feel like it's a good I don't think it's worth my time to do it because I know what the result's going to be.
Yeah. So I do it for a few reasons. A, for insurance purposes. B, because our surgeon always wants a tug.
Even afterwards.
Yeah. He's like, that is required pre, post op, and then on all re evals, you know? I don't see the value in it personally because I just like you said, they're not going to perform well. If if they come in with no symptoms whatsoever, then sure, like, okay, you can get up, you can walk, and I think that that's good for sure. But I just don't see a whole lot of like point to it. Like, there are other deficits that I can continue to work on. Your score is going to improve when your function improves, right? Like when
Yeah,
your symptom presentation goes down, you're going to be able to walk better. You're going to be able to get up better. You won't need to use an assistive device. I think those are all things that kind of just make sense. And so I don't do that, or like, I don't see the value in it. I still do it because they want me to. But I actually thought that you said that you performed like a 5 times stand previously, and I was like, dude, that's a lot. I would not give that for my patients. But now I'm realizing, oh, for your post ops, you don't do that. Maybe you do it for more of like your geriatrics, your older patients to kind of see where their functions at for some other musculoskeletal condition. But
yeah, I'll definitely do
that definitely makes more sense.
Yeah, I don't know. I don't find I get a ton out of it. I mean, maybe a tug would be good. Or what I will comment on is their safety, like their how if they need assistance to ambulate, what they're using to ambulate. Maybe I'll ask them, or I'll have them do like a step or two, see how they're doing that, gauge their safety with that. Like I'll put stuff in there regarding function. I don't find the need to have to perform those tests right after they had surgery. When it
Yeah,
becomes
I
relevant and they can actually perform the test at a level that you know like I said, a level that is like make that is makes the test relevant or appropriate, then I'll do it. But I don't do it right after. Like I said, I think I got enough deficits to justify their care and enough to work on when it comes to just regular walking, range of motion strength, right?
Yeah, I would definitely agree with that. That's like, you have more pressing issues to work
Yeah.
on. Like getting a tug is not going to do a whole lot for you, but they really love to see it. So that's the reason why I do it. The other question that I wanted to ask you is, how do you know and how do you educate your patients in regards to how much they should be doing, like how far they should be walking, how many times they should be doing their exercises or reps and stuff like that? Is there something that you use or that you tell your patients to keep an eye out for to help them know like how to progress themselves?
Yeah, I use, like, we mentioned this in the very beginning when it came to shoot, oh, I forget exactly what we're talking about, but like that symptomatic response, especially when it comes to swelling, to me is like the biggest thing. Like it's just, hey, if you do this exercise 5 times a day, 20 reps, and you're good, cool. Do a little bit more next time. You can push the range a little bit farther. If you do that and you get some swelling, and by the next morning you're not back down to baseline, it's still swollen, and you can't move your leg as far, all right, you're gonna have to back off a little bit. Especially in that immediate post op phase when we're talking up to like the 4 or 5 week mark. Yeah, the swelling response is a big thing. When we get past that, if that acute inflammation has settled down and it's just kind of pain and it's a little bit more individualized in that maybe it's someone who I know can handle a little bit more and it gets sore, but they can still do stuff. Okay, I'll tell them to push. If it's someone who once they have some pain, they immediately back off on their own, and the range goes down, and it gets a little bit stiff. Okay, their guidance might be like I might just have them work within relatively pain-free range, but the symptomatic response, in my opinion, guides most of it when I'm giving them recommendations for exercise and safety for sure, right? Like I'm not people who are like, oh, I'm gonna try and walk without the cane. It's like I don't know, or I'm gonna try and walk without the walker. I mean, I don't know. It's like day 3. Like maybe you should use it. Also, like
Yeah.
if they advance assistive devices too quickly, their quality of their gait it's just horrible. I don't want them to, you know, develop any funky patterns with that either.
Yeah, I found that in regards to the assistive device, that sometimes patients just go straight from the walker to no device.
Yeah.
Ends up being better than using a cane. That is the only way that'll usually like progress them past that. But yeah, I would agree. Taking away an assistive device too fast is definitely not the way to go. But if it's a coordination thing, for sure, I'm not giving them the cane. Like if their balance is good and they're like they have no other issues, sometimes it's just like they don't understand how to use it. It's another limb that you have to manage that they aren't used to. But to circle back, I think that is like the number one thing that I usually tell my patients is like, hey, if you want to see whether or not you can do something, try it. It's fine. Like do less. And if you find, oh, I had no issues, no other flare ups and symptoms, everything felt normal and good. Next time, do more. Like you should pretty much pick something or for patients, like they should pick something that they may think is too easy. Or they're like, why am I even doing this? Like this is like no challenge at all. I'm like, okay, that's awesome. Do that and then add to it. But the biggest takeaway for me is that I tell my patients that this surgery is pain limiting. There isn't anything you need to protect.
Yeah.
There's nothing that needs to heal. There's no repair.
You're not causing structural damage, right? You can push through it to some.
So the biggest thing is just like listen to your body, figure out what it's trying to tell you. And just like Mark said, like the biggest takeaway for like what they need to look out for is usually swelling. I'm like, hey, if you do too much, your body's going to let you know it's going to hurt. You're going to be swollen. That is like the number one response that I get if a patient or if I push them too much. And I'm like, I get it. Like, it'll happen from time to time, but for the most part, like you know that this is the case. So next time you just back off a little bit, and then they'll be okay and see if it goes down. And it usually will. So it's just like knowing that you're okay to push their function. You're not doing harm. I always say like I'm not someone who restricts activity, but you need to listen to what your body tells you. I will give you freedom if you know how to make intelligent decisions and choices, and that you can justify it. You know, if you've educated your patients, they will know what to do and what to expect. And sometimes you have to trust your patients to do just that, because it's easier for me to have a patient do too much rather than me having to push them to be like, hey, you really should get up and walk more. Like you need that motion. Otherwise, it's going to be a lot harder for you to recover just because you're lacking in that activity tolerance.
Yeah, I agree 100%. Yeah, I like those guidelines. So yeah, I like I definitely use that phrase like, hey, you don't have to worry about hurting it. I usually say, you're not going to cause any structural damage unless you like hit it, right? So it's like people are typically reassured in that regards. Oh, cool. So I can work into it a little bit. Even if it hurts, it's okay. Yes, exactly.
Yeah, I 1000% agree. All right, Mark. Is there anything else that you want to add to the topic for the day?
I'm good, man. Yeah, I think it's something we're planning on talking more about.
Yeah, I definitely think so. I think we have a couple more episodes in regards to this, just to touch on like different problems, like more stubborn knees or hips, and what we kind of do to circumvent those issues, and figuring out like, hey, when do we need to refer, or when maybe we haven't tried this intervention
Right.
or identified this deficit, and then like this could honestly fix the issue. And then also realizing, hey, like nothing's changing, like
Yeah.
this is
Yeah.
what your need, this is where your knee's at, and it probably will get better with time. But I think that comes with educating your patient with those expectations as well too.
Sure.
But those are some of the things that definitely have planned for the next time that we talk about this.
Yeah, but today we talked about, what we look at, what we're looking for evaluations before surgery, after surgery, the value of prehab, depending on the presentation, how we gauge expectations for patients, how we educate them before, what they should expect afterwards, the timeline of rehab, and then the kind of education and the guidance we give them afterwards. Can you work into pain? How to monitor your symptomatic response? And what they should do at home to get the most success and the most out of the surgery they had done. That concludes today's episode of the PT Good Podcast. Remember to leave us a like, subscribe to us on whatever platform you're listening to, follow us on Twitter at PT Good Podcast. Thanks for listening, everyone. We hope you enjoyed, and we'll see you on the next episode.
Miss you, love you, bye.